beautifully the etiology, the clinical picture, the management, the medical management of dry eye disease and ocular surface disease. So I'm just going to highlight another option in office practice that should be one day available in all our practices. It should be the gold standard, and it should be the thing that helps us to control the disease, not only the symptoms. Meibomian gland dysfunction or Meibomian gland disease, the TIFOS definition, the Tear Film Ocular Surface Society define Meibomian gland dysfunction as chronic diffuse abnormality of the Meibomian glands, commonly characterized by terminal duct obstruction and or qualitative or quantitative changes in the glandular section. It may result in alteration of the tear film, giving us symptoms of dry eye irritation and clinically apparent inflammation and ocular surface disease. The vicious circle of Meibomian gland, it was covered in previous lecture, but basically it starts with narrowing of the acini of the Meibomian glands and narrowing of the orifices of the Meibomian glands. This will lead to stasis of the meibum inside the glands. This stasis will lead to proliferation of commensal bacteria. The bacteria will release lipase that can change the composition of lipids in the meibum, increasing the level of esterified cholesterol. This type of new cholesterol and the new lipid has higher melting point. That's why our body temperature is not high enough for this kind of meibum to be dissolved and to come out from the glands in a normal quality and quantity. So we have seen today maybe 2-3 times this vicious circle, and it is part of a more common, more popular vicious circle that all of us are aware of, which starts with the tear film instability that leads to hyperosmolarity, apoptosis, cell damage, and nerve stimulation and inflammation, neurogenic inflammation that lead to the cytokine release and MMP release, goblet cell loss, and this cycle will become perpetual cycle, and it will repeat itself unless we interrupt it and we stop it. We can stop, we can improve the tear film instability with many other options that have been discussed today. We can control the hyperosmolarity. We can treat the inflammation with the anti-inflammatory drugs or with one of the options that I'm going to cover today. Topical treatment, of course, we have most of this in our region and in other countries, except the Mibo that was released last year, and the tear secretagogues, which we don't have here in our armamentarium, but it is available in USA. So is this enough? The eye drops that we have and the treatment modalities that you have? I don't think so, because dry eye disease is multifactorial. Lots of comorbidity can be addressed by drops only, but as such, there is no single gold standard diagnostic therapeutic option for this complex condition. So we need a holistic multi-modality approach. Lifestyle change, we have seen it in one of the presentations, the eye drops that we have, and in-office procedures that I'm going to cover today in my lecture is the way for modern dry eye disease management. These procedures will address and solve the problem of Meibomian gland dysfunction and the blepharitis. How to evaluate the Meibomian gland, its function and its anatomy? There is a very simple tool, office tool. We call it Corb Meibomian gland evaluator. It exerts a pressure on the Meibomian glands exactly similar to the normal pressure in the eyelid during normal blinking, which is 1 gram per square millimeter. We use this to evaluate the number of the patent glands, and then we evaluate the quality of the meibum. There are grades for the meibum. It can be grade 3, it looks like the olive oil, clear, transparent, fluid. Grade 2, turbid, gel-like. grade 1, it looks like toothpaste or spaghetti, and grade 0 when it is wax-like. We can do a meibomian gland score by counting the normal functioning glands and multiplying them by the quality of the meibum itself to give us a meibomian gland score. This tool, the meibomian gland evaluator, presses on 5 meibomian glands at a time. When we press with our finger, of course, this is too much pressure, but this to help us to know the quality of the meibum. Then we do the meibomian gland score, as I just mentioned. We look also at other signs like capping of the orifices. We can use meibomography to look at the structure of the meibomian glands. We can find truncated ones or areas of dropout. So what are the new technologies that we have? Actually, it is not very new, the intense pulsed light. We have it here now for almost 9 years in Dubai. It was the first country to have this technology after France. Now it is available in more than 50 countries. It is the leading treatment technology now for dry eye and the meibomian gland dysfunction, and I even learned from Dr. Shiti today that it has even more indication than what we already knew. The polychromatic regulated pulsed light, there is a visible spectrum and the non-visible spectrum. The energy spectrum and time period are precisely set to stimulate the meibomian glands to improve their function through stimulating the parasympathetic nerves going to the meibomian glands. The pulse in this machine, we call it regulated pulsed light. On the left, this is the normal pulsed light. On the right, this is the controlled regulated pulsed light, which is 100% of the emitted flash is regulated and does not fade away like in other machines that are used in many dermatological diseases. Each pulse in the machine consists of 8 subpulses of different intensity and different duration. The pulse is 200 milliseconds. The dark blue, which is of a lower intensity and a broader duration and longer duration, can be absorbed up to 4 millimeter in the skin, while the others can be absorbed deeper, up to 5 millimeter in the skin. The 2 branches of the parasympathetic nerve coming from the parasympathetic ganglia, they release the acetylcholine once they are stimulated because of the temperature gradient in the pulse that stimulates the Schwann layer in the nerve to release this. But other clinical benefits, besides the neurological stimulation, we have warming and the liquefying effect. This allows us to do expression, photomodulation, this enhanced collagen synthesis, reduce the vascular thrombosis. This is mentioned by Dr. Shiti, and it closes the telangiectasia at the lid margin. Antibacterial and antiparasitic, very important. It helps a lot with the Demodex and with other harmful organisms at the lid margin, and the tissue rejuvenation around the eye. Indication mainly evaporative dry eye disease because of meibomian gland dysfunction, ocular rosacea, lid margin telangiectasia, and Demodex. Contraindications, very important. The most important in the color of the skin. Number 6 is absolute contraindication to use this, while slightly lighter color, we can reduce the energy to use it quite safely. We do 4 sessions at day 1, day 15, day 45, and if the patient at day 45 is happy, we stop. If not, we give him a 4th session at day 75. After session 1, there is improvement for 1 week, after session 2 for 2 weeks, after session 3 for 3 from 6 months to 3 years, and the same after session 4. We apply a gel on the surface, we cover the eye, and we touch the skin, then we go back a little bit, like 1 to 2 millimeter. It is 10 minutes, no?
10
10
yeah,
minutes?
time is up, but it's okay. Maybe give another half a minute or a minute.
It is 10 minutes or not 10 minutes? If
No,
I
it is
finish
10
my time,
minutes.
so-
10-minute timer was there.
10 minutes?
Yeah. Over.
Okay, thank you.
Thank you very much, sir.
Thank you.
Thank you very much for this wonderful talk.